I'm going to tell you a story about a patient that came to the emergency department with a diagnosis of ascites and who looked for all the world like she had ascites but did not, and how point-of-care ultrasound was useful to us in this case. So this was a 10-year-old girl who had had a 2-year history of slowly increasing abdominal distension. And she'd seen a physician who had said, "This looks like it could be ascites. Perhaps this patient has some degree of portal hypertension or chronic liver failure," and had sent her for an outpatient ultrasound that confirmed the presence of free fluid in her abdomen, after which she was sent to the emergency department as sort of her intake to our hospital to get definitive diagnosis, a paracentesis of the fluid, and referrals onwards to the subspecialty services she needed. Sounded like a pretty well-packaged case, and this was not a patient who was acutely unwell, so we were trying to limit some of our throughput time in the ED and just connect her with the physicians that she needed for more definitive management. But being a point-of-care ultrasonographer and not running into very many pediatric patients or 10-year-olds that have ascites, I said, let's put the probe on and take a look at what this looks like. And I did my fellowship in a mixed adult and pediatric emergency room, so I have become accustomed to scanning patients with ascites and knowing what it looks like. You're going to see fluid in the same places you would find them in a FAST exam, in the dependent areas of the abdomen, in your Morrison's pouch or right upper quadrant, behind the bladder, in between bowel loops. You're going to see pockets between the anterior abdominal wall in a supine patient and the bowel itself. And with chronic ascites, you're even going to see subdiaphragmatic fluid that dissects the solid organs, the liver and the spleen, away from the diaphragm. And when we put our probe on this patient, instead of seeing this, we were confronted with a confusing picture. We couldn't visualize the liver or the kidney on the right. We could see the spleen and the kidney on the left, but we definitely couldn't see any fluid in the pouch in between them, in the splenorenal recess. In the pelvis, instead of seeing free fluid behind the bladder, we couldn't really find the bladder, and we saw what looked like a series of large cysts. And then as we scanned around the abdomen, we kept seeing this homogeneous, speckled fluid everywhere with some septations in it. So rather than thinking that this patient had ascites, we began to say this looks like a series of interconnected cystic structures, and diverted from outpatient management and referrals on to gastroenterology to, we think this patient needs more advanced imaging today and better attention paid to what this underlying diagnosis could be. And she ended up having 2 basketball-sized ovarian connected cysts of a mucinous cystadenoma, a phenomenally rare pediatric benign ovarian tumor. And it was the recognition of what ascites looks like versus what's referred in the literature as pseudoacites, or these rare cystic conditions of the abdomen or pelvis that can perfectly clinically mimic ascites, that allowed us to better diagnose the patient, avoid a potentially harmful paracentesis, and get her the care that she needed.